Hello and welcome to lecture 11 of the Principles of Exercise Undergraduate Physiotherapy program. The last in the first semester sessions, we're talking about exercise rehabilitation planning and the components of fitness. The things that we'll be looking at from the Principles of Exercise Therapy are specificity, progression, overload and timeout, otherwise known as SPOT. So in this session, the learning outcomes are going to be as such. We want to apply the goals of rehabilitation planning. That's the entire process. Apply the principles of specificity. We're going to rationalize how exercise programs satisfy the overload principle, formulate the appropriate exercises for progressions and regressions, know the importance of rest and recovery between exercises so we're not overtraining or under-recovering, and implementing SPOT. So this is our centering side, what physiotherapy is about. We're concerned with human anatomy and physiology, human movement and function, maximizing wellness and potential, and minimizing disease and injury, and solving the real world problems. So within the principles of exercise therapy, SPOT or specificity, progression, overload and timeout, they're going to be our focus for rehabilitation planning. And the reason is that these are potentially not done as well as they could be done in the rehabilitation planning process. So we want to begin with the end in mind. So the goal is to make sure that the patient or the client is maintaining their fitness with exercise. So they might have physiotherapy very early on where we're targeting very specific parts of rehab. They might then need some supervised exercises where they might be part of a group or some individual training, and then we want to push them into their home exercises, either going to a gym or using their own gym. And we've got 3 stages of rehabilitation: the early stages or the acute stages, mid-stage or subacute, and then the late stage, which is the chronic stage. So it's important to recognize that the SPOT principles will change according to where they are in the rehabilitation continuum. So we talk about a patient's journey, and what I want you to do is I want you to start with the end goal in mind. So for instance, if they're a footballer, that is back playing 90 minutes of competitive football. That is when their rehabilitation has finished, not when they can just walk again or run again. They're going to have to be doing cutting drills, jumping drills, agility drills. And that's what we call end stage or late stage rehab. And that is very different to the early stage or the acute stages. So there's 3 stages here. There's obviously going to be some tissue healing. We're concerned mainly with things like range of movement, strength and some motor skills. Here we've had some healing. They should have full range of movement. We're concerning with maximal strength, more balance and proprioception, maybe getting into some motor fitness. And then the end stage, we want to make sure that they're back to where they were, which is their previous baseline. And here we'll be working on things like power, and all the motor components of motor skill that we need. We should already have the physical side here. So it's important that we recognize these 3 distinct layers of rehabilitation. We have given you the exercise clinical reasoning model. With your exercises, we've got to think about the description. So what do they need to do, and what is that individual capable of? Observe them having a go at the particular task if they're able to do that, or as close as they can to that. Then we're going to link that to our knowledge base. So why are they struggling with that particular task? Is it a range of movement issue? Is it a strength issue? Is it a power issue? Which component of fitness are they lacking? We form a hypothesis, and then we prescribe exercises accordingly, and then after those exercises have been done, we're going to evaluate them. If it's a physical component of fitness, there's going to be a physiological adaptation time to take place, and that will be weeks and months. If it's a motor skill, we might see that very, very quickly. So just be aware of the time needed for that training effect to occur. So we've got to think about tissue healing. Obviously, you're going to have an injury to the tissue. Then we're going to go through the stages of inflammation. Then we're going to go through some regeneration of the tissue. For bone tissue, this might take quite a long while, so we've got to be mindful of that. And then back to normal tissue function and getting them exercising again as they were. But each stage of this process will require a different exercise prescription. I'm going to introduce you to the exercise physiologist now. So whenever you've got a patient that's on long-term training, you'll normally have an exercise physiologist working with you, and they will be focusing on things like weight loss or metabolic conditions, on chronic conditions like diabetes, cardiac rehab, cancer, mental illness, and they also do strength and conditioning, and they manage training load, and they're very good at that. My first degree was in exercise physiology, so I am both an exercise physiologist and a physiotherapist, so I know the difference between the two. And you can see that the physiotherapist works alongside the exercise physiologist. They do similar jobs but not the same, and it's important that we recognise another clinician that will be working with us. So the principles of exercise therapy and the SPOT principle. So specificity is the key to what we're doing. We need to make sure that our goals are specific to what we want at that stage of rehab. Okay, and this is taken from Claire Minshall's work. You can hear her on the podcast. So we've got these 3 pillars. You've also got the time out, the rest and recovery. We'll talk about that in a minute. Okay, but basically specificity. So what you train for is what you get. And then progression. Progression is massively important. So a lot of patients stay at the same stage because their physios have not progressed their exercises. You've got to continually improve until you reach that rehabilitation plateau, which will then apply the law of diminishing returns. And we've got to make sure that we're overloading the patient as well, making sure that we're progressively overloading in a sensible way, not more than 3 to 5% per week if we're talking about things like strength, so that they get that physiological adaptation to what's going on. And Claire's given us a model very kindly. This is from this year as well, about what sorts of components of fitness we need at what stage. So you can see in the early stages, we're going to need, when we've got a lot of pain, we're going to need strength. So we're going to do a lot of strength training in the early phases. And you can see that strength training then just maintains. So we do a lot at the beginning and then we just maintain it. And then you can see that we do very little power training, which is a combination of speed and strength, until right at the end. So it's only when we get to this kind of subacute, this middle stage rehabilitation, that we start training power. When we're talking about balance and proprioception, coordination, accuracy, all the motor skills here, you can see that you need all of them for a very long period of time, that strong foundation, and then they can tail off. But early in the rehab, we're doing loads of strength, loads of range of movement, loads of balance and proprioception. And if we're talking about things like gait, that will and the sensory motor abilities, that will come a lot later in the rehabilitation. So it's a really nice little way of demonstrating where we need the components of fitness and at what stage. Remember the 4 P's of functional movement. The movement must be purposeful, either task orientated or meaningful to the individual. We've got to think about what position they're in. Are they a rower? Are they a cyclist, in which case they'll be sitting? Are they a footballer, rugby player, hockey player, in which case they'll be standing? Is it simply just walking that's the task? What position they're going to be? And then where are the joints in space? What sort of joint alignments do they need? Things like golf, tennis, any sort of rotational or twisting movement. And then we've got our pattern of movement here, which is normally one of the 7 functional movements that we learned about in lesson 3. So when we're talking about specificity, we've got to ask, what movement is required and what level of functional movement. So obviously we've got 3 levels of functional movement. Then which components of fitness are required, either motor or physical, and then the individual's capability. Can they perform the function? Do they have certain limitations? And for that we do the needs analysis, and that will be something you learn next semester. We do a whole session on that, and really that's about 2 things. It's the individual and the task. So what's the current impairment status of the individual? What components of fitness do they need? What's their current age? and what's their previous exercise experience, all of which will be factored in. Then we've got the tasks. What task are we doing? What functional movement? Where on the 4 Ps where are we doing this? And how can we break the movement down into sort of bite-sized and manageable chunks? So what outcome measures? So we've had our session on outcome measures. If we're measuring flexibility of the calf, for instance, is it the knee to wall? Are we measuring muscular endurance, balance and proprioception, strength? Where are we going with our outcome measure? Remember that if you're not assessing, you are guessing. Overload. The overload principle is really just applying more. We use the DRIVE acronym: duration, rest, intensity, volume and energy system. So we can either increase the repetitions if we're working muscular endurance, or increase the load if we're working for strength, or we can increase the speed so we get the intensity, or we can decrease things like the rest time. And the rest time, for example, would be things like Tabata. That's an example where we decrease the rest time. So here's our table where if we're working strength, you can see it's 85% of our 1 repetition max. If we're working muscular endurance, it's 67% of our 1 repetition max. Greater than 12 reps, okay, less than 6 reps. So be aware of that. A nicer acronym is this one here. So you can see that if we're working strength, it's up to 6 repetitions. So you can't lift the weight more than 6 repetitions. So we've got to get out of this 3 sets of 10 bodybuilding hypertrophy phase that's great for the gym but not useful for patients, or we're working more muscular endurance, which is far more useful. So normally we're concerned with strength or endurance. We're not concerned with building muscle mass. That's for the bodybuilders. So when we're trying to work out 1 repetition max, there's a nice way of doing that because most people won't be able to lift their 1 repetition max. So for instance, if we're doing bench press and you're going to be bench pressing 60 kilograms for 10 repetitions, which is not unreasonable. Okay, so you times the amount of, and that's to failure. Okay, 10 repetitions by 2.5. Okay. And then we minus that from 100, which gives us this, and then we divide that number by 100, which gives us our decimal point, and then we divide the weight that we lifted originally by this new number, and that gives us our 1 repetition max. And this is a guesstimation, but it's very, very safe. What it does is it allows us to work out our 1 repetition max from effectively an endurance event. So progression and regression, you can start with the weight of the limb against gravity, then use your body weight, then resistance bands, then resistance or load or weight, and then add load in the functional movement. Okay, so you might, for instance, do a single, like a quads contraction, then you might do a knee extension, then you might do a knee extension against gravity or with the band, then you might add an ankle weight, and then you might add a squat, lunge or gait, because they're the functional movements. This is our 6-step model. Okay, we've covered this before. Okay, isolating and integrating, adding some resistance, adding functional positions, increasing function with resistance, multiple muscle groups, okay, and then more components of fitness on that one. So progression is simple. We've just got to make sure that we're progressing in terms of either repetition or load, depending on what principle of fitness we want. So timeout. Okay, it's really important that we get this super compensation. Okay, this is exercise, okay, effectively damage, okay, and then we get this super compensation here, okay, where we recover greater than the exercise. And we want to keep going up and up and up and not down and down and down, otherwise that's overtraining. Okay, we're going to cover things like acute chronic workload ratio. So this is a really nice way to stop us overtraining. So we're going to talk in terms of arbitrary units, and we're talking about the rate of perceived exertion out of 10, and then how many minutes you train for. So for instance, if you trained rate of perceived exertion 6 out of 10 for 100 minutes, that would give you an arbitrary unit of 600. Okay, if you did that 3 times a week, that gives you a score of 1,800 arbitrary units. So if we're going on to that, how many units are you doing weekly? And then we divide that by 4, and that gives us our chronic workload. So to work that out, you divide your acute by your chronic, and that gives you a score. Between 0.8 and 1.3 is fine. Anything over that and you're overtraining. So there's an example